Now, if you are diagnosed as a result of an early screening event or recognizing symptoms in yourself or a loved one and having a comprehensive memory evaluation, what is available to you today living with Alzheimer's disease? There are 5 FDA-approved medications. I'm going to show you the next slide first, okay? There are 5 medications. 5 seems like a pretty good number, doesn't it? I mean, 5's a pretty good number. We have about 5 things on the market that we could take if we have a headache. We could take Tylenol, we could take Motrin, we could take acetaminophen, we could take aspirin, right? So we've got a number of things. So it seems like 5 is a good number. But when you start to dig down and understand how these drugs work, we realize of the 5, there are only 2 mechanisms that are being treated. 3 of the drugs have the exact same, 4 of the drugs have the exact same target. The target is class on the right-hand side, cholinesterase inhibitor. They all do the same thing. You can't take, you don't need to take Aricept and Exelon, they're all doing the same thing. So really 4 of those 5 drugs all do the exact same thing. So we no longer have 5 different available treatments, we really only have 2. The last drug, Namenda, or the generic name memantine, has a different site of action, and that's why we say we have 5 drugs, but only 2 classes. They really only target 2 things. And oftentimes, we will prescribe them in combination. There are a number of different ways in order to take them in combination, and you would get the maximum effect if you take it in combination. The reason for that is on this slide. I'll go back to it, I promise. I want you to understand why, how the drugs work and why we prescribe them combinatorially. I understand they're expensive. I do understand that. And sometimes, cost prohibitively, we don't take that. The second thing I understand is that they're not free of side effect. The number 1 side effect that I hear about is gastrointestinal distress. And so a number of people simply cannot tolerate taking the medications and they feel worse on it. The GI effects outweigh the cognitive benefit they may be getting from taking it. The third thing I hear is, my loved one didn't improve. He or she is not doing any better on the medication. And so we stop taking it. So that's why this slide is important. I'm going to describe how the medicines work and what the expectation of the medicine should be. Up in the right-hand corner, or actually in the middle of the slide, is a neuron. I've already told you the cells of the brain are beautiful. They're much like us. They have a body and very long projections that make the communication networks. We're going to focus on the long projections, specifically where the partnership in our game of telephone would take place. That's called a synapse. So in the box up above is the ends of 2 neurons coming together to have that message transferred from one to the next. The upper half is called the presynaptic neuron. It's the one that's doing the communicating, it's talking. The bottom neuron is the postsynaptic cell, and it's doing the listening and the interpretation of the message. Okay? The way in which neurons talk to each other is a language of neurotransmitters. These are small chemical molecules that are produced by the cells themselves and go across. They flow from one cell to the next, and along with it, carry the message. The amount of volume that I'm talking to you right now, we can consider I'm the presynaptic neuron, and you're the postsynaptic neuron. And the volume with which I'm speaking to you is kind of like the amount of neurotransmitter, the amount of small red balls I'm letting out.
If I talk to you like this, maybe some of you can hear me, but probably a short range.
When I turn the volume up, a lot of you can hear me. This is what those drugs do. The acetylcholine esterase inhibitors, the group of 4 that I first showed, make it so that when those neurotransmitters, depicted by the little red balls, are released, they are able to hang around for a longer period of time. The longer they hang around, the more of the message they can share. It's like me using the microphone to turn the volume up on my communication with you all. The other class, the receptor antagonist, the one drug at the end of the table, is working on the little blue ears of the postsynaptic cell. It's as though you're listening with a hearing aid and you turn up the volume on your hearing aid. You now receive the message of the neurotransmitters more clearly and can respond to them better. This is why we prescribe them in combination. Because if I talk with a microphone and you turn your hearing aid on, now we're really talking loud. We're really communicating. And so this list of 5 drugs, the top 4, the choline esterase inhibitors, are allowing more neurotransmitter to stay there for a longer period of time and communicate the message louder and for a longer period of time. The last drug, Namenda or memantine, the receptor antagonist, is allowing the listening cell to hear that message more clearly and respond more effectively. We prescribe them, if tolerable, in tandem so that you get the best return on taking the medication that you can. Yes?
Could you spell those last 2 campaigns?
Yes. The ones that you'll probably most likely encounter commercially, the cholinesterase inhibitor that is most widely available in pill and patch and combination treatment is Aricept. ARICEPT. It is also marketed under the generic name of Donepezil. DONEPEZIL. That is the most widely prescribed cholinesterase inhibitor. Of the other class of drugs, there is one. It is commercially marketed as Namenda. NAMENDA. And its generic is memantine. MEMANTINE. I'm going to show you why, in actual data, we prescribe them together. So this is a graphical representation of how individuals who are diagnosed with Alzheimer's disease perform with the natural progression of the disease. The natural progression of the disease is shown by the slope of the red line. This is determined by using the memory tool mini mental status exam we talked about for screening. The individuals over a variety of years, demonstrated on the bottom, take the mini mental status exam. As their disease progresses, as more and more plaque and tangle formation occurs and more cells die, over time they perform more poorly on the mini mental status exam. That is what the red line is showing you. When given one of the 5 treatments, either acetylcholinesterase inhibitor or Namenda, the receptor antagonist, their rate of decline is sharply attenuated, and it's represented by the slope of the green line. Now, what's important is that the decline still happens because I showed you how these drugs work. Now, when I showed you, did I say anything about plaque? Did I say anything about tangle? No. These drugs are not disease modifying. The disease still progresses in the background. You still have plaque formation and tangle formation. The drugs are actually working on the remaining healthy cells in our body that are not yet impacted by the plaques or the tangles. It's the healthy cells that are given a boost in their ability to communicate and form meaningful relationships. This is why the notion of staying is actively, intellectually, and socially engaged as throughout your whole life is so important for minimizing risk. The more cognitive reserve, the more cellular connections we have, and those connections are based on experience. Remember we said the game of telephone. Every network is specific and unique for every sensory input or experience we've had in our life. The more of those connections we have, the more we can rely on when Alzheimer's begins to impact us, the more good relationships we have that we can maximize with these drugs. So while they're not disease modifying, they can impact our ability to maintain a cognitive function that slows in terms of decline and stays for a period of about 12 to 18 months is the effectiveness most individuals enjoy. So when patients come to the clinic and say, I took my loved one off of the therapy because they weren't improving, that is what's so difficult for providers to help educate them. It's not that your loved one is going to be able to now do what he or she couldn't do. You are reducing the rate of decline of tomorrow with these drugs. So what we're looking for is a plateau, is a maintenance of performance and function once the medications are started. And what's particularly heartbreaking is that after that individual comes to the clinic and says, oh yes, we stopped those medications. And then 3 or 4 months later, after they've stopped the medication, they come back to the clinic and say, he's doing so much worse. I don't understand. It's all of a sudden something has changed. Then they realized that the medicine was doing something. It was slowing the progression. It was slowing that rate of decline. And they put their loved one back on the medication, but recognizing now that they already experienced that decline, and now there's a new plateau they're at. So I certainly don't want to tell you how to medicate and manage your disease or your loved one's disease, but I want you to be educated and understand the expectations of the treatments that are currently available and how and why they work the way that they do. Our research efforts definitely are aimed at targeting the plaques and the tangles, but the medications that are currently available do not do that. In fact, there are healthy people that take Aricept, right? People who are in the military and are involved in vigilance tasks, or pilots, for example, who do transcontinental flights, need to maintain a heightened attention for a long period of time, can get a cognitive boost from taking Aricept. You and I would get a cognitive boost if we took Aricept. So again, because it's not disease modifying, it's working on the cells that are still healthy and as yet impacted. I have a couple of figures just to belabor this point, and I don't think you need it, to show that when you take one drug alone, you have a certain degree of maintenance of function, and when you take 2 drugs together, you have an even greater degree of maintenance of function. I don't think anybody needs that point belabored. This is a little bit of a timeline of the progression of Alzheimer's disease. It underscores why I said memory screening is so important, and it also speaks to where our therapeutic advances are targeting in terms of clinical research and prevention. The first thing that happens, likely in our late, if not mid-50s, is the generation of the amyloid plaque walls that are beginning brick by brick to be built between and among the communicating cells of the brain. This is demonstrated by the red line. It happens as the first hit, so to speak, and it happens silently. It's happening without any kind of outward expression. We're not yet experiencing forgetfulness or signs and symptoms of dementia that might cause us to go to the doctor. It doesn't cause us pain or discomfort, and it's not changing how we look or act, so we're living with it blindly. As a result of the accumulation of the plaque over time, our brain activity does begin to change, and we start to experience mild forgetfulness, maybe lapse or challenged processing speed and working memory. And that is usually closely associated with when that second pathological feature is beginning to form, the tau tangles. This is when we might experience first symptoms and begin and kind of push them under the rug, or start to sort of tune out our loved ones or family and friends around us who are calling our attention to it, and we say, no, it's not us. We start to deny or refuse to recognize those changes that are happening in our daily activities. Then we have the cells that are experiencing the environment of plaque and tangle begin to die, and our brain actually gets smaller. If you look at a picture of the anatomy of the brain by MRI, this is why MRI studies are part of the comprehensive diagnosis. The holes in our brain, we really do have holes in our brain. They're the ventricles. They're meant to be there. They're fluid-filled spaces of our brain. They get bigger. They're bigger because the cells that once used to be there are not there anymore. Okay, if you take the brain out of the skull, at autopsy, for example, and you weigh it on a scale, it weighs less. There are fewer cells there. This is why we begin to experience the symptoms of dementia. This is when we go to the doctor. We get our diagnosis. I appreciate that. That's important to know what we're dealing with. But it's too darn late for the treatments that are currently on the market. Sometimes it's even too late if we wait too long to be able to participate in research that is your only chance of accessing a drug that may be disease modifying. Because most of those trials close enrollment at moderate Alzheimer's disease. Why? Because those trials are aimed at targeting amyloid and tau. And if we wait till we are so far into the process that the tau tangles have already formed and the amyloid walls have already been built, then those drugs are not going to help. And so that's not the target population. So we're not enrolling them in those individuals who have more late, moderate to advanced Alzheimer's in the research protocols. So the walk back of identification and diagnosis to the earliest stages possible is so important. It relies heavily on the expertise of your community physicians, and it relies heavily and puts the burden on you to tell them you want your memory screened and you want to play an active role in your brain health. One of the ways, in addition to community-based memory screening, that we are aiming to serve the population in Sun City Center is not only for you to be able to access free memory screening, but if you are diagnosed with an early form of cognitive impairment, or if you are potentially preclinical, where you are beginning to develop risk in your brain, plaque and tangles, but not yet experiencing symptoms, we have research that you can benefit from. The problem is, up until very recently, it was happening 35 minutes away up I-75, and it was somewhat difficult for you to access and become part of. That is all changing. Last year, we were successful at getting Tallahassee and your local legislators to recognize that the only opportunity for individuals to access treatments that could potentially alter the disease process is through participation in clinical research. And that clinical research is only going on in a handful of academic medical centers throughout the state of Florida. And oftentimes it's not in the backyard of where the residential communities of the largest populations of people who may benefit from that research reside. For example, the villages, for example, Sun City Center. So many wonderful, vibrant communities of older adults that aren't necessarily built around a college town for a variety of obvious reasons. So we decided to say all of the things we do in clinical research, well, why do we have to do them in the Institute? Why couldn't we do them on the road? So we were discussing the increased accessibility to participate in clinical research by the development of the mobile memory suite. One of the goals of the mobile memory suite is to allow individuals to get access to potentially disease-modifying treatments or preventions in the comfort of their neighborhood without having to travel to an academic medical center. We've equipped, it's a 68-foot tractor trailer. And we tried to make it look as pretty on the outside as we could, but ladies and gentlemen, it's a tractor trailer. We put nice awnings on it and great images to make it a little bit more comfortable and aesthetically pleasing as you arrive. If you can't negotiate the stairs, we do have a wheelchair lift, so it is wheelchair accessible. Don't allow those stairs to fool you. On the rear set, alongside of it is a second door, and we do have a full lift apparatus that will come out. You do not need to transfer. You can stay in your mobile device, just wheel onto the platform and we'll bring you in. Inside the unit is likewise all ADA compliant. In fact, the vendor that we commissioned to develop the unit said this was the largest restroom on a mobile unit he ever made. But our university compliance officers made it mandatory that we had an ADA compliant bathroom that allowed one in a mobility, an assistive device to be able to do fully 360 in the room. And so we have a very large restroom, as you can see. We have a traditional exam room, a universally designed exam room, so a physician can do a traditional E&M visit, evaluation and medical management visit, with a full extending exam table. We have a blood draw and lab phlebotomy station where you can have your blood tested, spun down and prepared for laboratory analysis. And then we have two, only one is shown on the bottom left panel. We have two of these on the unit, two interaction and interview rooms. These are the kinds of rooms that when you do take your memory screening test or any other kind of assessment for your memory, we like to use. They are scarcely furnished, they are sound attenuated, and they are traditionally designed to only service the individual and one or two caregivers or proxies. And that's where the preponderance of your visit with one of our clinical coordinators takes place. That was really all I was going to present today in terms of new information. I did want to share with you that the clinical mobile unit has begun making appearances. And I'm going to put Sun City Center on the spot and call upon all of you in the room to help me identify who the community contact would be to bring the unit to the parking lot outside. Because it's a big unit. It does, I want to say first and foremost, the host site does not need to subsidize this activity in any way, shape, or form. The unit is fully functional autonomously. We do not need a landline. We do not hook up to water. We do not hook up to energy. It has a generator, it has water on board. Everything is self-contained. We just need somewhere to park it. We would be supplementing the memory screening activity that's provided along with our partners down in Sun City Center when we're here. We will likely staff the facility not only with our clinical coordinators, but potentially, if we can get approval, with a provider so that we could do evaluation and management patient care, at least minimally for those individuals who are participating in research studies. We have 4 contracted research studies on the unit already. We've only had it since June. And we have 4 trials. And they are ranging in their target audience. We have prevention, we have mild cognitive impairment interventions, and we have mild to moderate Alzheimer interventions offered from the unit. We are trying to accept trials on the unit to reach the broadest audience possible and have something for everybody. That being said, I do need to express it is not always possible to enroll an interested party in a trial. Sometimes he or she may have other health conditions or circumstances that render them ineligible from participating. It isn't because as a provider we have a bias or don't want you to have access. It's because in the data gathering stages, it is important to control the population that we're looking to see the response to the drug as much as is possible. And so sometimes there are other conditions that you may have or circumstances that prohibit us from enrolling you in a clinical trial. But nevertheless, the way in which you become first contacted or can identify yourself as someone who wants more information to potentially participate in the activities offered on the mobile unit is by, one, doing memory screening with your local organizations down here, the South Shore Coalition for Mental Health and Aging and your Rescue Squad volunteers. At the end of that visit, they give you the opportunity to join the memory care registry. This is a database. It is completely HIPAA compliant. It is private. It is not sent or shared with any other providers that may solicit you without your consent. And it is where we house the contact information and relevant medical information necessary to know before we call you that you are potentially eligible to participate in the activity we have to offer. And so doing the memory screening will automatically put you into the memory care registry. If you want to be added to the memory care registry outside of memory screening, then I'll invite you to visit the table in the back. Kara will be happy to give you the contact information for how to have yourself added to the registry. I do want to give you two pieces of information now so that you're not disappointed by learning them later. In order to participate in the vast majority of research opportunities, if they are targeting the disease condition, you must already have a diagnosis. So you cannot come with just a memory screening evaluation, and you cannot come with a I think I have. You must have a physician's diagnosis. It doesn't have to be by one of our physicians, but it must be a diagnosis. And then our physicians will submit the medical history and documents to the sponsor, and they will determine whether or not that diagnosis is appropriate and valid. So waiting until the call is not the best avenue. You have to line your ducks up first. Getting your memory screening and understanding where in the spectrum you lie. Should you be thinking about prevention or early intervention or intermediate intervention begins with a screening and then a comprehensive evaluation to know whether or not you have a diagnosis and what that diagnosis is. The second thing is, again, identifying yourself. We don't know who you are or where you live or how to access you if you don't identify yourself. It is so confusing, and I understand this. Everyone in the community has the word Alzheimer in their name. And we all wear purple. And although we do all collaborate and we do interact socially and sometimes even academically, for example, when we participate in the Alzheimer's Association walks, we have our table there. The Alzheimer's Association is coming to our institute on Thursday, and they'll be distributing their literature and information. But we are not one and the same in the extent of sharing private and confidential information related to either your health status or even your contact information. So identifying yourself with one organization does not identify you across the board. So sometimes we have people come to us and say, well, we signed up and we were supposed to get information and we didn't. oftentimes if we trace those steps back, it's because you thought that you were identifying yourself to a group of individuals that you weren't. I just call your attention to a couple of events that you may find interesting or helpful. They're listed above here. In addition, I told you already about the ongoing memory screening that's offered in Sun City Center at those multiple locations. The information is on the back of the Sun Tower flyer for how to get yourself an appointment. But Thursday, we have our National Memory Screening Day at the Institute. This is we offer free memory screening at the Institute every day, but this is the day in which we conduct no other activity, and all hands on deck perform memory screenings for everybody who comes in the door and is appropriate to have a memory screening. This would be appropriate if you don't already have a diagnosis. I have to caveat that. There's no sense in doing a memory screening if you already have a diagnosis. But on November 17th, in addition to memory screening, we will have a variety of other activities. We will have clinical pharmacy, we will have blood pressure checks, we will have hearing checks, balance checks, self-conducted driving evaluations. It's like a whole health fair at the Institute. There are informative seminars, and there is a flyer describing the date, time, and events that we are hosting back on the purple table. And it is free, but it is up in Tampa. The other two listed activities are things that we do quarterly, and the first we do at the Institute. This is we limit the audience of this program to, Kara, is it 30 for the caregiver workshop? 40. Okay, the reason we limit this to such a small audience is because it's kind of like a support group on steroids. We get very personal. We deal directly with examples from the participants of how to manage undesirable behaviors, how to improve activities of daily living for their loved one that they're providing care to, and how to effectively communicate and live with somebody with Alzheimer's disease. And so it isn't a seminar program where we're speaking to you and sharing information. It is very dynamic and very personal, and so that is why we limit the audience to 40. We had been doing them monthly, but getting that we're near the holidays, we found that there isn't as much subscription, so we probably won't have another one of those until closer to the holiday, dealing particularly possibly with issues that arise during the holidays, and then we'll go back after the holiday in the springtime to offering that monthly. The other program that we do on a routine basis and often take on the road, we've done it a number of times in Sun City Center, is a seminar program. Now this could be delivered to as large an audience as we have here today. It is not the kind of one-on-one personal example that I described, where we bring our experts to you and we do more like what we were doing today. It's more a didactic, educational seminar where we do cover strategies for communication, for behavior management. We do talk about medication and other management strategies of the disease. We may talk about rehabilitation and occupational therapy, home safety, driving evaluations, all of those kinds of things. But they are more demonstrative, using examples from our experiential knowledge or academic environment, and not necessarily what the audience is giving us as a how do I deal with. Those are free to attend. We offer them at the Institute quarterly, and we do, as I said, often take those out into the community. Okay, so do I have questions? I know, I think I answered your question, how to get access to any of the activities that may take place on the mobile unit.
One question, in order to participate in that testing, you say you have to have a diagnosis, but you've already told us that if you have the disease, if you have a diagnosis that you have the disease, it's most likely too late.
No, if you are already, okay, so the diagnosis is not a one-size-fits-all, you have Alzheimer's disease. About 4 years ago, the DSM-5, the Holy Bible that dictates what the diagnostic codes are in medicine that a physician can give you as a diagnosis, were updated finally after about 20 years to reflect what's really happening in Alzheimer's disease. And so now we have stages that we can clinically diagnose. We have mild cognitive impairment. We have early Alzheimer's disease or mild Alzheimer's disease. We have moderate and we have late. And the trials traditionally are geared in those same tiered recruitments. So we have trials that are addressing mild cognitive impairment. We have trials that are addressing mild to moderate Alzheimer's disease. We do not frequently have pharmaceutical intervention trials for late Alzheimer's disease, because many of those drugs, as I said, are targeting the pathological development that is already very downstream in late Alzheimer's disease. We do, however, have trials associated with behavior management techniques. We have trials perhaps for medical devices that may be assistive for individuals living with late Alzheimer's disease. We also have trials for caregivers, for approaches to minimize caregiver stress, improve caregiving. And those may be offered not only by us, but by our colleagues in nursing, in aging studies. And so there is a continuum of research that you may be able to participate in. It's usually the drug pharmaceutical treatments that limit eligibility to moderate and less severe forms of the disease.
So Dr. Banko, just so that, because that's a lot for everybody to kind of decipher through. Once someone were to have a memory screening and submit their information through to the Institute, when you receive that information, would you then reach out to them and say you could qualify, or should they then reach out to you and say, I have my memory screening?
Actually, what should happen after a memory screening is, and after your memory screening encounter, your memory screening administrator is going to give you a results and recommendation. It's your take home. They don't give you the test to take home. They give you your results and your recommendations. Your results and recommendations may be as what I would say from least severe to most severe, okay? Depending on your performance. Your recommendation may be, come back in 12 months. We don't suggest you follow up with any healthcare provider. Just keep getting your routine memory screening. Then we may say, follow up with your primary care provider because you were experiencing some challenges on your test. You don't have a preponderance of risk factors for Alzheimer's disease or other dementing disorder, but you do have sleep apnea and you're not using your CPAP. So go back to your, or you have a thyroid condition and you're not taking your thyroxine or whatever that case might be. So we may recommend you go back to your primary care physician and discuss your circumstances with him or her because we think it's something at that level that can be addressed. If your performance warranted evaluation with a memory care specialist, we could make that recommendation. We do not then call you from our doctor's office. This is not a referral service for our physicians. If you need a comprehensive memory evaluation, you have physicians in Sun City Center that can do that. You have Tampa General's clinic, you have geriatricians performing here. Dr. Resdine, oftentimes for very complex diagnoses, might send individuals up to the tertiary care clinic at the Institute. But you have local providers who can do that, and we recommend you seek their counsel and their services in doing so. We will equip you with the education of what that should be, what should be included in that comprehensive evaluation, so you know you're getting what you should get. But it's not a direct referral to our practice. Again, unless it's prevention targeting, you do need to come into the trial with that diagnosis, not just the memory screening. So we're not using that registry as a, we will contact you and solicit you to come to our clinic. So you do need to take that next step on your own. If your recommendation is go see your provider or get a memory evaluation, you need to do that. That is first and foremost, that's the point of the early identification of memory screening. So that is your tamale to cook. Once it's been cooking, then is the appropriate time to say, what are my options? Do I want to go with a treatment that is on the market today that is symptomatic? And importantly, most if not all of our trials, you stay on your medication. If you're already taking Aricept and Namenda, you stay on that. And then you add to it whatever the disease-modifying medication is. Some trials even require you be on a certain form of management, symptomatic management for a period of time before they will enroll you in their trial. So every trial is different, every sponsor has different eligibility criteria. The registry allows you to identify yourself with as much upfront information to know that you may likely be eligible for the opportunity that you're seeking or that we're looking to fill. And it kind of gives that first pass, but it doesn't mean one way or another. It doesn't mean you're definitely going to, there's a trial that will fit or that there's not.
Okay, so then the 419-4902, that's your number here in Sun City Center to call to get scheduled for a screening at one of 5 of the different locations that we're doing in South Shore. As with it being 10 till 12, we're going to take one more question. You get
Okay. Oh, don't do that.
I can't do it.
I'll tell you what, we'll take one more. If it's a personal experience, a loved one's medication or an appointment sorting out kind of question, leave your hand down. I'll be over on the side. We can talk about that privately. If it's something more appropriate for the group to hear, I can't not put the lady in the blue. Oh my gosh.
All right.
I'm sorry. I promise I'll come back to you. I'm so sorry. She's just like, she's barely in her seat.
I think this will be appropriate because there's probably a lot of veterans in the group. And so I wanted to know, how does the Institute relate to the VA?
It doesn't.
There you go.
Okay, but let me qualify that. Okay, so here's the thing. We don't select the insurance providers that will allow us to provide medical care. We are not that kind of organization where we say we accept this insurance or we don't. We do not require a particular kind of insurance or a referral from your primary care to come to us. We don't require that as a front door pass like some specialists do. That being said, your insurance may not allow you to come to our practice without either first going to your primary care physician and giving you a referral, and or may not accept coming to a specialist for the condition for which you think you have. And so we will do that legwork for you when you call the Institute and ask that you would like to make a new patient appointment. We will do that legwork for you. But I want you to know ahead of time, and I don't know the circumstance with VA benefits. I would purely be speculating. We do have lots of wonderful collaborative relationships with providers in the VA. They do have actually a superb memory program at the VA in Tampa across the street from us. I'm less familiar with the one at Bay Pines, but is it the J.A. Haley, James A. Haley program? I mean, we work very collaboratively on a number of academic pursuits, and so, in fact, both of our geriatric psychiatrists who do our primary diagnosing were fellows trained at the VA. So I can speak to the quality of the care, but I can't speak to the insurance piece. You can call our clinic and we will do that legwork for you.
Will you take money if someone doesn't?
We do self-pay. So first of all, most of the people, a vast variety of you, I think even if you have VA benefit, don't you also have Medicare? Okay, so we pay Medicare. So you can kind of put your VA benefit aside and just use your Medicare if you have Medicare. Yes. Oh my gosh, I just broke the rule and I took another one. Yeah. If your primary care doctor refused to give you what? He's refusing to, I'm still not.
Your doctor's saying, I don't want to give you that diagnosis because it's related to your brain. In other words, so you would be saying that to go maybe to Tampa General?
I would suggest, if you believe that your doctor's diagnosis is not correct, or you would like a second opinion, which, okay, here's the thing, guys. You gotta be educated consumers. right? You don't go out and buy the first car you test drive, you don't go out and buy the first house you walk into. Your doctors are just like the rest of us. Sometimes they make mistakes, sometimes they don't know what they don't know. And so it's really important to feel comfortable with the diagnosis, and there's absolutely nothing wrong with seeking a second opinion. If your doctor objects to you seeking a second opinion, get a new doctor. Because I'm telling you, all of my providers in our clinic would say, you want a second opinion? Here, let me give you recommendations of people I hold in high regard who are qualified to give you that second opinion. All it is your time, and it's your help. Take command of it. Absolutely seek that second opinion. And if it's not, if you're not comfortable or you don't have a referral here in Sun City Center, then of course you can come up to the Institute. I just want it to be something that is convenient for you and you're not gonna have a problem accessing.
And so on Thursday,
Oh, absolutely. And many primary care physicians will not be able to provide you with all the elements of a comprehensive memory evaluation because it is either outside the scope of their discipline or they're part of an HMO or something where they cannot offer you the kinds of diagnostic imaging and tests that are required to do a comprehensive memory evaluation. Perfectly legitimate. Doesn't mean your doctor's not good. It just, my primary care doctor doesn't do my knee surgery, right? That's why we have trained neurologists and geriatric psychiatrists. And geriatricians. Those are really the most appropriate types of doctors who are familiar and have enough experience to diagnose memory conditions.
so you come back another day soon.
These are always so great. I'm always afraid that I'm coming back and I'm saying something stale. I feel like, oh gosh, maybe they've heard this from me before. I'm so grateful.
No, and so with Dr. Banko here, and I know we're talking Caregiver Symposium, but this one for brain health, to be a good caregiver, you gotta have it.
You have to take care of yourselves first.
Absolutely.
So many of us sideline our own health care needs among other personal needs because our duty and our burden as a caregiver is so great. And that becomes what we are living for and through. And again, as Debbie said, you have to absolutely take care of yourselves. And I recognize the difficulty with finding respite, finding daycare services and others to be able to do that. Is so much a part of why we're trying to bring to the extent that we can, some of those services to your communities to help alleviate some of those access issues.
I'm excited. I'm so glad you came.
Okay, so